I really respect very much, people that do things, because I think that it's important to speak about a technology or something when you actually do it, and you can talk about the pros and cons and your personal experience with the patients. Dr. Reddy is author of numerous publications on Index Journal, is a leading and a key opinion leader in the field of electrophysiology and left atrial occlusion. And today will be here with us talking about left atrial appendage occlusion, state of the art. Thank to join us, Vivek.
Thank you very much, Luigi, for the very kind introduction. You called me a giant in the field, and I do have to confess I've gained a little weight, but I'm trying to lose it. So hopefully, but I do hope that this presentation is interesting. There's been a lot of work in the left atrial appendage occlusion space, a lot of recent new data for the past couple of years. So I'm really excited to be able to give this talk in a sort of a grand rounds format. Before getting started, note that I do have a number of disclosures, and those relevant to this presentation are in yellow. Probably most importantly, most of this presentation will be on concepts as opposed to technology, but there will be one slide near the beginning, and I'll point to it, where I talk about different technologies, most of which are not yet FDA approved or in various stages of regulatory approval, but I'll point that out. Now, before getting started talking about appendage closure itself, let's talk about the conceptual basis of appendage closure. And probably most importantly, does it make sense to perform local therapy to treat a global issue, which is stroke? And I think this is a really important conceptual issue. Now, all of us have seen patients like this. You see the thrombus here, and I don't think it takes much of a leap to say, well, when you have that, if that embolizes, that's going to cause a stroke. If you take that out of the equation, then patients will do better. I think that's straightforward. The question is not, can that happen? The question is, how often does that happen? That is, what is the potential for thrombi outside the appendage, of cardioembolic thrombi outside the appendage? And now there's older data that's looked at this, but that was somewhat contaminated by rheumatic heart disease, et cetera. This is a recent study a couple years ago that actually has a lot more patients than most, over 1,400 patients, of which 6% had atrial thrombi. And when you look at where the thrombi are, what you see is that 99% of the thrombi are in the left atrial appendage. I think that's a really important point. Now, the second question is, what about the sort of so-called non-cardioembolic stroke? What about strokes coming from outside the appendage? Certainly, occluding the appendage wouldn't deal with that situation, right? Well, how often does that happen? And I guess probably more importantly, how can you deal with that situation? Well, there actually is a fair amount of data, and these are some of them. There are older studies like Wars and Wassid, which compared aspirin versus warfarin to address these so-called non-cardioembolic strokes. And the more recent studies that have looked at the NOACs, Navigate and Respect thesis, and Atticus. Actually, Atticus has just been published, at least it was presented. I don't think it's been published yet. But what's interesting, and I'm showing you one of the studies here, Navigate. And what's interesting is that basically the NOACs or warfarin are no better than aspirin in preventing these non-cardioembolic strokes. And this is the primary reason after appendage closure that the so-called vascular strokes we try to prevent with aspirin. And I think this is a really important point. So a NOAC is going to have no additional benefit over aspirin in preventing these so-called vascular strokes. So patients that are at high vascular risk, yes, they will have the potential for non-cardioembolic strokes, but they can be dealt with a baby aspirin. Now, the next question, of course, is, well, aren't NOACs sufficient? Why are we even thinking about appendage closure? Well, there are a couple of problems. Number one, thrombi occurred despite NOAC use. And this is a recent publication that looked at thousands of patients, a total of 14,000 patients from 35 different studies. And what you see is that despite oral anticoagulation use, and specifically despite NOAC use, you have a thrombus rate of 2.73%. Importantly, this occurs whether the patients are on VKA or on DOACs. And importantly, this, not surprisingly, it is more common in the patients that have higher CHA2DS2-VASc score. When you have 3 or higher, the incidence is as high as 6.3%. So NOACs are excellent drugs, and I'm certainly not trying to suggest that we shouldn't use them. It's the primary approach that I think most of us use to try to prevent strokes, but they're not perfect. The second issue is that NOAC discontinuation is a real problem, and it has important consequences. When you have poor NOAC adherence, that increases the risk for stroke, and this is dependent both on an increase in CHA2DS2-VASc score as well as an increase in the amount of time that you're off oral anticoagulation. There are a number of studies that look at non-compliance. So this is discontinuation, let's say because you have to have a surgical procedure or whatever. But there are also a number of patients who permanently discontinue because of bleeding issues or et cetera. So I think, and I don't need to go too much into that. I think we're all aware of patients from our own practices. All right, let's move on to appendage closure. Now, let's talk a bit about the technology. These are the FDA-approved devices. The original Watchman device, which now has been largely supplanted by the Watchman Flex device, and we'll talk more about that. There's also the Amulet device, which is a slightly different mechanism, but ultimately, and then there's a number of other ones. So these are all not FDA approved. They're various stages of clinical trials in the US or Europe, the different style devices, the Lariat device, which does have regulatory clearance, but is not approved for stroke prevention. Ultimately, whatever device you use, what you're trying to do is this, which is to take the appendage out of the equation. So here's the picture of the device, and then compared to baseline, a year later, you can see where the device is and how the appendage has been truncated. Now, after implantation, the standard regimen that we started with these devices was to give an oral anticoagulant and aspirin for 6 weeks, though now the aspirin has largely dropped out. So typically we just use a NOAC for 6 weeks, followed by DAPT for a period of time, usually 6 weeks, followed by aspirin. More recently, with both of the approved devices, now there's also the approval of DAPT regimen for 3 months, followed by baby aspirin. Again, remember the baby aspirin, particularly in the high vascular risk patients, to prevent non-cardiovascular stroke. Now let's talk about the various patient populations, and first let's talk about what is the stroke reduction potential of these devices. And I want to split these patients. Oh, I'm sorry. After talking about stroke reduction, we'll talk about the safety, mortality, and data that's really emerging, which I'm very excited about, which is the data on stroke severity, which I think you'll find interesting. So stroke reduction. These are the populations, and there's a lot of gray here, and I appreciate that. But let's just talk about them in broad strokes. There's the OAC ineligible, the poor candidates for long-term, and the OAC eligible. Now, the initial randomized trial were in this population, those who could take some short-term oral anticoagulation, but not really long-term. There was the original PROTECT and PREVAIL studies, which basically took non-valvular AF patients and randomized them to warfarin or Watchman. And then there's the more recent PROG 17 study, a smaller study, randomizing NOAC versus appendage closure, either Watchman or Amulet. Now, I know people have already heard a lot about PROTECT and PREVAIL, so I don't want to go into detail about that, though I'm certainly happy to talk about that. But there's a lot of other data. This is the PROG 17 trial, and this is the most recent data that we published, I think, late last year or the year before. It was a trial of 402 high-risk patients. You can see the CHA2DS2-VASc was 4.7, and they were randomized to either appendage closure, Watchman or Amulet, or NOAC, which is basically apixaban, because 95% took apixaban. This is the long-term 4-year follow-up, and here's the data. The primary endpoint was a composite of all those things we care about: embolic events, cardiovascular death, bleeding, or procedure-related complications. And what you see is on the modified ITT, you can see that this did reach non-inferiority. It has a ratio of 0.81 favoring appendage closure. Appendage closure is in orange, but this is non-inferior. So no statistically significant difference between groups. This was true on the modified ITT, the per protocol, or on the on-treatment analyses. Now, if we look at the individual components of the composite, the first thing, again, I want to emphasize is that this is only 402 patients, and the trial was not powered to look at these individual components. But of course, we have to look at them. So if we look at all stroke or TIA, you can see overall no difference between groups. But again, notice the wide confidence intervals. So I think this is just hypothesis generating. Cardiovascular death, interestingly, again, no statistically significant difference between groups, but 32% fewer cardiovascular deaths with appendage closure. I'm going to come back to that because I think this is important. And then if you look at clinically relevant bleeding, particularly non-procedural bleeding, about a 50% reduction. This is a meta-analysis that we published a few years ago, looking at taking all 3 randomized trials, 1,500 plus patients, average follow-up of over 3 years. And here's what you see. Overall stroke rates are similar between groups. If you look at the type of stroke, there are more ischemic strokes with appendage closure, but this is not statistically significantly different. But it is balanced by much fewer hemorrhagic strokes. This also drives the decrease in non-procedural major bleeding, as well as the decrease in cardiovascular and all-cause mortality. Again, I'm going to come back to the mortality question. Now, this is only 1,500 patients. I think we do need to recognize that 1,500 is a lot, but it's not that many patients, particularly when you look at the NOAC trials, which are tens of thousands of patients. But this isn't the only data we have. We now have a lot of non-randomized data, some of this very high-quality data, with tens of thousands of patients. I want to show this to you. Now, when looking at these data, you really have to, since there is no comparator, we really have to look at what the baseline risk of this population is to understand what any ischemic stroke rate means. So this graph here shows, and particularly this dotted blue line, shows what is the expected ischemic stroke rate off oral anticoagulation. And we're showing it as a function of the CHADS-VASc score of each population. The orange represents the ischemic stroke rate on oral anticoagulation. So if you have a data set where the ischemic stroke rate is right here, right on the orange line, and that means it would be as good as oral anticoagulation. If you had it somewhere in between these 2 lines, it would mean that it's worse than oral anticoagulation. If it's on the blue line, it means it has no effect whatsoever. And if it's above the blue line, it means it's even worse than being on no therapy. So where are we? I'm going to go through some data sets. And these are the point estimates, these little triangles. There are several high-quality FDA registries, over 3,000 patients, the CAP and CAP2. And if we look at the Pinnacle Flex using the Watchman Flex device, look at the ischemic stroke rate. Look at, for the Amulet ID, again, a very high-quality study comparing Watchman to Amulet ID, and you see the point estimates for these two. There are also some very high-quality non-FDA registries. There are actually even more now, but these are the ones that I thought were high quality at the time that I made this slide. And there are also some claims databases. There's the CMS claims as well as the NCDR registry. Now, I have to confess, I'm not terribly confident that the ischemic stroke rate in the NCDR registry is really 1.5%. I think it's probably higher and that there were some that were missed. But I think the strength of the NCDR is we're talking about 37,000 patients, almost 37,000 patients, where all the patients were included. Your renal failure patients are included, the extreme elderly patients are included, everybody's included. There is no exclusion. And I think it's reasonable. Any one of these data sets, you could say, well, you know, we don't know how real that is and representative. But when you look at the aggregate and you see how all these point estimates hug this line, this orange line, I think that this is compelling data, particularly in combination with the randomized data. Now let's get back to our little triangle. What about the OAC in eligible patients? Well, there are a couple of trials that are looking at this. But before getting to this, I want to address a question that often comes up, which is people look at the Averroes trial and say, wait a second, aren't NOACs, particularly apixaban, just as safe as aspirin? Because if you look at the top line major bleeding component, you see no difference between groups. And it looks like, well, what's the advantage of doing anything, particularly if patients have to stay on aspirin? Well, this is not quite correct. One of the important points is when you actually read the details, if you look at the on-treatment analysis, meaning you actually look at the patients that actually took the apixaban, then what you see is that the hazard ratio is 1.54. There was actually 50% greater bleeding events, major bleeding events with the apixaban group. But even more important is this point. When you look at the type of patients that were in Averroes, it was not a high-risk population. It's most striking here. The number of patients who had a prior bleed before entering Averroes was only 3%. I want to underscore that. Averroes was not a high bleeding risk population. This was only 3% of patients had a prior bleed. So then the next question is, well, what if you are a high-risk patient? Well, if you go to the extreme, there's two very interesting trials that have looked at this. One is Apache, and the other is SOSTAR, and both have been published in Lancet Neurology. Both of these trials randomized patients who had a previous intracranial bleed to either apixaban or nothing. And here's what was seen. if you look at overall ischemic stroke rates, basically no difference between groups. So adding apixaban in this population did not improve ischemic stroke rates. And probably the major reason is because of this. The intracranial hemorrhage rate was dramatically higher, 8% versus 2%. So apixaban increased the risk of intracranial hemorrhage by 4-fold. This is not a very large study, only about 100 patients because it's difficult to enroll. But this is not the only study. The other one is SOSTART. This is a similar design. And here what was seen, and this is the ITT analysis, but let's focus on the on-treatment analysis, again, the patients that actually received the therapy. And what you see is the risk of spontaneous intracranial hemorrhage is substantially higher in those that started the apixaban. So thus far, there's no evidence that apixaban is a reasonable stroke prevention strategy in the high-risk patients. Now you can say, well, okay, that's fine, apixaban is not good. Well, what can we do? Well, I wish we had randomized data. Unfortunately, we found it very difficult to enroll patients in this contraindicated trial. ASAP2 we ran for almost 5 years, couldn't finish enrollment. Of the goal of 888, about half the enrollment was done, and finally we gave up. We're still actually in follow-up, so we'll see what it shows. There are 3 other European studies, again, looking at high-risk patients, looking at appendage closure versus no appendage closure, and these are, again, struggling with enrollment. But we don't have no data. Look at this. This is a very high-quality propensity match analysis. In this one, Jens Erik Nielsen-Kudsk, who's done some really nice work, he's looked at patients who had who received appendage closure in the European registry, in the Danish appendage closure registry versus the Danish stroke registry in patients who had a previous ICH. And here's what you see. This is standard of care for this primary composite endpoint, and this is with appendage closure. And this is again after propensity matching. If we look at the components, you can see that there's a 70% reduction in major bleeding. Not a big surprise, I think. 90% reduction in recurrent intracranial hemorrhage because these patients are not on oral anticoagulation, but also an 80% reduction in ischemic stroke and a 90% reduction in mortality. So I think there's very good data, especially now that we can put these devices just with antiplatelet transition to use these patients in these very high-risk patients. Let's go to the other end of the spectrum. What about the OAC eligible patients? Well, there's very little data on this population, and this is why the randomized trials, some of which are ongoing, are so important. Let me just talk about a couple of them. OPTION is an interesting trial that's finished enrolling, looking at AF ablation patients, randomizing them after ablation to either appendage closure or NOACs. The trial is finished enrolling about a year plus ago, and now is in follow-up. So another year, year and a half, I believe, we'll see the data. There's also the WATCH TAVR trial. So patients who are undergoing TAVR who also have AFib underwent either TAVR or TAVR plus appendage closure. And this actually, these data are supposed to be reported later this year, hopefully at ESC or American Heart. So that'll be interesting data. The 2 big trials are, of course, CHAMPION and CATALYST. CHAMPION uses the Watchman Flex device. CATALYST uses the Amulet device. Both of these devices are large, multi-center, multinational trials of about 3,000 patients each, where higher risk patients are randomized 1-to-1 to either appendage closure or NOACs, and with significant follow-up. So these are great trials. The CHAMPION trial is completed enrollment, is in follow-up. Amulet is enrolling, and I would encourage all of you to please enroll patients in CATALYST to try so that we can get these data and treat our patients better. Let's move on from efficacy to safety. So when you think about safety, I think that this is the original Watchman device, and I think one of the major issues with the original Watchman device is that as it came out of the sheath, the delivery catheter, you had these sort of the splines that could be a more traumatic pose and cause damage to the appendage. So if you look at all of the clinical trials, now initially in the very beginning of PROTECT, we had almost a 5% tamponade rate. Then later in PROTECT, that dropped down to between 1 to 2, and then later to about 1% in the clinical experience, which is manageable. But I think the real importance is that the Watchman Flex device has been approved and now in clinical practice for several years. And this clearly is a better device when it comes to the potential for tamponade. This is the Pinnacle Flex registry. This was the regulatory trial through which the device was approved, a 400-patient trial. And what you see here is a 0% rate of pericardial tamponade. I think that's quite remarkable. Now, it is reasonable and fair to say, well, listen, that's an IDE trial. That's your best operators, probably very experienced. What about in clinical practice? Well, this is the clinical practice data. This is the NCDR data, the so-called SURPASS sub-registry of over 16,000 patients. And again, the tamponade rate was 0.5%. And just recently at CRT, these data were updated to now, I think, like 30,000 or 40,000 patients using the Flex device, and the tamponade rate is still about 0.4%. So I think from a traumatic perspective, there's now very good data about this. The other issue is device-related thrombus, and I'll put this under safety. I want to talk about this. I think it's an important issue. This is a foreign object, part of the reason why we put these patients on an antithrombotic regimen. And the question is, can thrombus form on the device? And the answer is yes. Fortunately, it's not very common. Unfortunately, it's not rare. So here's the data. If we look at the FDA trials, the DRT rate, device-related thrombus rate, was 3.7%. And it's important because when it happens, as shown in blue, the subsequent ischemic stroke rate increases by fourfold. So this is a non-trivial issue. This is true for the Watchman device. It's true for the Amulet device. Also increase if you have a DRT. So I think this is one of the reasons we have to be careful about DRT, and if we see it, we treat it. But I want to keep this also in perspective. Let's look at what is the actual impact. So if you look in the appendage closure patients, and here we're looking at ischemic stroke rates, what you see is in this population, the ischemic stroke rate, as shown here, is the same as what's expected with the oral anticoagulation. This is not a select population. This is all of the oral anticoagulation patients and all of the appendage closure patients, including all of the DRT patients that are cooked in here. And of course, both of these are better than if you're not on oral anticoagulation. The other important thing is the percent of patients that actually are DRT positive is actually pretty small. So DRT is important. It does increase the risk for stroke, but the actual percent and the impact and the total percent of patients that get appendage closure is actually relatively small. Of course, that doesn't mean we don't want it to be better. This is data with the Watchman Flex device, which has less metal, and it looks like the DRT rate may be lower, though I think these data need to be corroborated because this is only 400 patients. But I think what's really exciting, and this is something that we're going to see in the United States, I think by the end of this year, is that the device is evolving. And I should note, again, this is not FDA approved what I'm talking about. But this Watchman so-called Flex Pro has some sort of a surface treatment where in the preclinical studies, the healing is much better and less chance of device-related thrombus. This is going to be FDA approved, we believe, later this year. And the really exciting question is, will the DRT rate be so low that we can implant the device without even the initial antithrombotic regimen, just putting the patients on aspirin? So that's a study that is supposed to start later this year. I think it's very exciting. And hopefully this will be even better for those very high-risk patients that can't even do well with the short-term antithrombotic regimen. All right, let's move on to mortality, because I think this is one of the most interesting aspects of this. We know for the meta-analysis, and I already showed you these data, both cardiovascular and all-cause mortality are less. In fact, if you just look at Protect and Prevail, the NNT to prevent one death at 5 years was only 16. It's actually quite remarkable. But of course, warfarin isn't standard of care. Now we've moved on to NOACs, which are obviously excellent drugs. I've already showed you the PROG-17 data. I'm not going to spend too much time on this, but I do want to spend a few minutes just looking at this again. This is the cardiovascular mortality data. Again, this is not statistically significant. I want to underscore that. There's only 400 patients in this trial. On the other hand, with only 400 patients in this trial, there was already a 32% fewer cardiovascular deaths with appendage closure. So I think we're all very excited to see what the larger randomized trials tell us. But this isn't the only data that's consistent that appendage closure results in less mortality than NOACs. There are some propensity match analyses, and there's 3 major propensity match analyses that have been published over the past 3 years, one each year actually. This is one by Jens-Erik Nielsen-Kutsk, where he took patients in the Amulet appendage closure registry compared to those patients in the Danish registries on NOACs. And what you see is that those patients on appendage closure in red did better than the oral anticoagulation, the DOAC patients, with about a 50% reduction in mortality. This is a propensity match analysis. There's also the Optum administrative database. This isn't claims, this is an administrative database with a large number of patients, 8,000 appendage closure, 500,000 NOACs. After propensity matching, again, you see a 27% reduction in mortality with appendage closure in red. And more recently, there's a Medicare claims database. Now, this is a claims database, and you can only get so much data from it, but here's what the data that was observed. And here the investigators separated this into those patients who are male versus female. So these curves are the mortality curves in the men and women after appendage closure, men and women after NOAC. And again, what's interesting is that in both cohorts, there's about a 50% reduction in mortality. Now, I think it's important to recognize that when you do these propensity match analyses, particularly when you have large claims databases, they're inevitable confounders. There's no two ways about it. But I think particularly in concert with the randomized data that we have, and the fact that all the outcomes are concordant, and there's a couple other smaller analyses, but every time this has ever been looked at, there's always been a reduction in mortality, makes a compelling argument that probably is going to be a mortality benefit of appendage closure over NOACs. There certainly is a mortality benefit of appendage closure over warfarin. But of course, and I do absolutely think that we can't be 100% sure of the benefit over NOACs until these bigger trials, Champion and Catalyst, are done. Now, one of the arguments that's been levied against this mortality benefit is that, well, it doesn't make mechanistic sense. And I just don't think that's correct. And let me give you 3 arguments why that is not correct. The first is the issue of hemorrhagic stroke. Hemorrhagic stroke results in death. And if you decrease hemorrhagic stroke, you'll have less death. And this is true whether the patients are on warfarin or NOACs. This is a study that looked at patients who sustained an intracranial hemorrhage while receiving either NOAC or VKA. And what you see is that when you compare these, if you have an intracranial hemorrhage, you will have a large intracranial bleed, there will be hematoma expansion, and 90-day mortality is basically 30%. That's true whether you're on VKA or NOACs. And remember, NOACs are much better than warfarin with intracranial hemorrhage, but they still have intracranial hemorrhage. There's no two ways about it. There's also just generalized bleeding, and this is a really interesting study. Here, the Aristotle investigators looked at patients who had a major bleeding event and looked at their subsequent 30-day mortality. Now, not surprisingly, if you have an intracranial bleed, your subsequent 30-day mortality increases by an odds ratio of over 100. I don't think that's a surprise to anybody. But what was somewhat surprising to me is that when you have a non-intracranial bleed, your subsequent 30-day mortality also increases by 1,000%. And this, by the way, was true for both warfarin as well as apixaban. So bleeding is bad. And by the way, that's not, I don't think that comes as a surprise to anyone. We're now learning, or we have learned, even with the stent trials, that bleeding with the antiplatelet agents also increases mortality. The third one I think is probably the most exciting, and I personally believe maybe the biggest contributor for the decreased mortality, which is this whole issue of stroke severity. There's emerging data that ischemic stroke, which certainly can occur with appendage closure or NOACs, but there's data that these ischemic strokes may be less severe in the context of appendage closure than NOACs. Let's talk about stroke severity for a minute. So there's a little bit of a digression. We know that AF-related strokes are typically severe. There's a lot of data showing that. And we know that strokes are typically categorized as being hemorrhagic or ischemic, and hemorrhagic or worse. But it's also important to recognize that ischemic strokes also range in severity. This matters to patients, by the way. This is a study that looked at patient values and preferences, and it looked at this so-called health state utility scores. Now, to explain this, a score of 1 is perfect health. A score of 0 is basically death. And here's how patients look at this. Major bleeding, they look at a score of 0.6, so somewhere between perfect health and of course, death. A minor stroke is typically viewed very similar to a major bleed. This is, again, patient sort of perception. And not surprisingly, a moderate stroke is often viewed as bad as death, and a major stroke is viewed actually worse than death. So patients do care about the severity of the strokes, and certainly I think physicians do. What is the data on this? Well, this is a nice study looking at consecutive patients that presented to the center with an ischemic stroke in the context of atrial fibrillation. And the investigators said, well, how bad are the strokes? There are different groups. There are those that are sort of on or undertreated, meaning no anticoagulation, on antiplatelets only, or subtherapeutic VKA, and those that are adequately treated, therapeutic VKA or NOACs. And here's what you see. If you ask what percent of these ischemic strokes are either disabling or fatal, if you're on or undertreated, it's about 70%. And this is, by the way, consistent with the other data. If, on the other hand, if you receive an oral anticoagulation, it's substantially reduced, but it's still about 50%. So about 50% of ischemic strokes that occur in the context of oral anticoagulants, even NOACs, are disabling or fatal. This is a single study. This is a meta-analysis, again, showing similar data. If you look at stroke severity, whether it's on therapeutic VK or NOAC, is better than not being on anything. And if you're undertreated, then it's actually worse. Why is this, by the way? Well, it seems that it has to do with the size of the embolus. So this is a really interesting study looking at 330 patients who presented with ischemic stroke in context of AFib who had brain imaging. Again, the undertreated and the adequately treated. And here's what's seen. If you look at the size of major vessel occlusion, meaning large vessel occlusion, what you see is that those that are adequately treated, there's less of the major vessels that are occluded. And this translates to a smaller brain infarct volume. So the size of the embolus is reduced with oral anticoagulation. Okay, now that's oral anticoagulation. What about with appendage closure? Well, there are two pieces of data I want to show you. This was published a few years ago. Here the investigators asked a very specific question: are ischemic strokes different when they occur in the presence of NOAC versus appendage closure? They looked at patients who were in the Korean Multi-Center Stroke Registry versus a number of appendage closure registries, and they took those patients who sustained an ischemic stroke despite these two individual therapies, and they looked at modified Rankin scores. And here's what was seen. Compared to baseline, if you look at the NOAC patients, there you see the increase in the MRS scores, meaning greater severity. And notice that with appendage closure, they're not quite as bad. That's at the time that they present to the hospital. And over time, with 3 and 12 months, you can see that the NOAC strokes stay severe. And again, that's consistent with other data, versus the appendage closure strokes actually get a little bit better. Now, this is one piece of data. Let me show you another one. This is actually data that from our own experience, from a multi-center experience of 8 different centers in the United States. This is an abstract, and this is being put together as a manuscript. But let me show you this first cut of the data. Here, we looked at patients, consecutive patients that presented to the hospital with an ischemic stroke, either while having been on oral anticoagulation, specifically NOACs, or after an appendage closure device. The primary outcome was looking at stroke severity, both in hospital and in 3 months. And ultimately, we enrolled these patients, 98 patients after appendage closure, mainly Watchman because that's the most common device used. And with NOACs, they're relatively split between apixaban and rivaroxaban. And here's what's seen. If we look at the population, who are these patients? Not surprisingly, the appendage closure patients are a little older, a little bit sicker with higher CHA2DS2-VASc and HAS-BLED, and have a slightly higher rate of hemorrhagic stroke before they presented with this ischemic stroke. The overall rate of ischemic stroke, previous ischemic stroke before the current one, was similar between groups. And here's the data. If you look, and this is percent of strokes, ischemic strokes again, that are disabling or fatal, what you see is that at discharge and at 3 months, you can see that the appendage closure, it's about 50%. And again, at 3 months, it's about a little bit better, but again, about 50%. Note again, this is completely consistent with all the other studies that I've showed you. In contrast, if you look at the appendage closure patients, you can see that the ischemic strokes are less severe, less fatal. So I think when you look at all these data, and these are statistically significant results. So when you look at all these data, I think, and I'm sorry, the other important point is this is looking at all the raw data, all the consecutive patients. When we propensity match them, the data looks almost identical. In fact, even more favoring appendage closure. So I think the point is ischemic strokes are more severe in the presence of oral anticoagulation, particularly NOACs. And while there are confounders that are minimized, we should also recognize, though, that these data are limited by the lack of randomization. Do we have randomized data? Well, we do have some randomized data. It isn't perfect, but let me just show you what we have. This is from the FDA studies. High quality data, I think everybody would agree. So if you look at Protect, Prevail, Rely, Aristotle, Rocket, and Engage, those patients that were on warfarin, if you look at those that had a stroke, you can see about half the strokes were disabling or fatal, okay? If you look at the NOAC arms of these trials, again, half the strokes were disabling or fatal, entirely consistent with the literature and the other data that I've showed you. But if you look at the Watchman patients, you can see that it's only about a third or a little bit less than that are disabling or fatal. So I think when you look at this in aggregate, what we see is that ischemic strokes are indeed more severe when occurring in the presence of oral anticoagulation, particularly NOACs. Why might this be? Well, it could be, again, if the appendage is not occluded, there may be larger thrombi that might embolize. That might be one mechanism. The other one is that when you have an ischemic stroke on a NOAC, you're on a NOAC, so that may cause more superimposed bleeding into the brain. Versus with appendage closure, except for the very initial time point, you're largely off or anticoagulation. So I think these are interesting hypotheses. I don't think we know the answers to this yet, and certainly this needs to be investigated further. Now, let's see. Yeah, I have a few more minutes. So I think in the remaining time, I want to just address a few other points. There are a lot of questions that are raised about appendage closure. One is the question of what about the leaks, because I think it's a very important point. Another question is, well, if you start doing appendage closure, people are just going to put this in everybody and just completely indiscriminate use. And the third issue is the question of cost. Isn't a procedure very expensive? So I want to address each of these issues, and let's start with leaks. So this is data that relatively recent data, and I should say because older data suggested that small leaks really don't matter in terms of increasing risk of stroke. Now that we have more patients, longer follow-up, clearly that's not the case, and actually this has been published now in Circulation last year. Let me show you the data. We looked at the patients in the FDA trials with Watchman. Over 1,000 patients followed for almost 5 years with excellent TE follow-up. And here's what we see. With the initial Watchman device, 28% of the patients have some degree of leak, either smaller or bigger, at the 1 year time point. And very importantly, if you do a landmark analysis and say, starting at 1 year, what is the subsequent risk of ischemic stroke? This black line represents the ischemic stroke rate if you have zero leak, and this blue line if you have a leak. And basically, the risk approximately doubles. So there's a hazard ratio of 2. By the way, these are not annualized rates. The annualized rates are substantially less, and I'll show you that in just a second. These are absolute rates over 5 years. What is the nature? What is the type of these strokes? Well, interestingly, when you look at stroke severity, the disabling and fatal strokes between those patients that have no leak versus leak is really no different. The increase in stroke that occurs with leak are largely non-disabling strokes. I think that's important. I'm not trying to say they're not important at all. I think that may speak somewhat to the mechanism of these. The other important point, and I don't think this comes as a surprise, is that since these are largely non-disabling, overall mortality is no different if you have a leak or no leak. So the increase is driven by an increase in non-disabling, no increase in mortality. The other important point is, what is the impact? And I think this is, again, I showed you this before, but I'm going to show it to you slightly different. If you look at the ischemic stroke rate in this population, this includes all the patients with leaks. There is no selection here. This is everybody. You can see the overall ischemic stroke rate is the same as what you expect with oral anticoagulation. Of course, both are better than if you were not on oral anticoagulation. The second question is, what percent of these patients are impacted by this leak issue? And it turns out it's substantial. About half the strokes, or half the patients who have these ischemic strokes, despite the therapy, have had some amount of leak. So this is an important issue. And it also is very interesting when you look at it and ask the question slightly different. If you look at the ischemic stroke rate in those patients that have no leak versus leak, what you see is that if you don't have a leak, the ischemic stroke rate is only 1.2%, which is pretty extraordinary. That's actually, I think, quite low. And this provides a glimpse into the possible, meaning that if we can put this device in without no leak, we can have a subsequent ischemic stroke rate, theoretically, that's very, very low, of 1.2%. Is that a pipe dream? Well, I don't think so. If you look at the Watchman Flex device, for example, what you see is that the peri-device leak rate in the IDE trial was only 10%. And actually, there was an analysis that was just presented last week looking in the NCDR registry. The 1-year peri-device leak rate in thousands of patients in the United States after Watchman Flex was only 15%. So we're getting better. It's not perfect, but we're getting better. There's also other devices, such as the Amulet device, which I think interestingly has a deflectable sheath, and soon the Watchman will also have a deflectable sheath, so we can manipulate and hopefully position in a more coaxial fashion. And perhaps by improving the coaxiality, we may decrease leak further. Again, I admit that this is still a hypothesis and we still need to prove this. What if there is a leak? Well, there are ways we can deal with this. We can use coils, and this is an example where these are coils that are used for neurointervention. You can put a catheter behind and put them there. Here's an example. There's a leak past the device, and here you put a bunch of coils and put a lot of them until there's really no leak past the device. You can also use plugs. This is work that Luigi and others have done where, I'm sorry, actually, this is actually coils again, showing the same sort of experience. This is our publication showing this. Again, this is work from Luigi and others, looking that you can even use RF ablation in certain patients to plug the leak. And you can also use plugs, small amplets or other types of plugs that can close the leak. So I think leaks are important. They're getting better, but they're manageable. And despite the leaks, we still have a good low rate of ischemic stroke. The second point I addressed was this whole issue that people are going to be putting this device willy-nilly. That's just not where the data is. This is from the LAO registry, which shows all the patients that are receiving the device in the United States. And what you see in this 38,000 plus patients compared to the clinical trials is that the mean age was actually higher than what was seen in the clinical trials. It was in older patients who are higher risk with a mean CHA2DS2-VASc of 4.6, with a 30% had a prior stroke, 11% had prior intracranial bleeding, and 70% had prior major bleed. So the point I'm trying to make from this is that these are not just being put willy-nilly. They're actually being used like they were intended in the randomized clinical trials. And this shows you the population, the type of patients. Interestingly, the majority of the patients are Caucasian. We actually have relatively little data in non-Caucasian patients. I think that's one of the big questions still that remain. Until we get the results from Champion and Catalyst, I think most implanters are sort of avoiding those patients who just want to get off the drug just because they don't want to be on it. I don't think that's the right way to go at this point when we don't have the data. Economic analysis, and this is the last point I want to really address, which is this whole issue, is an appendage closure just too expensive? So we did this economic analysis, and we had several of them that we published. This last one we haven't published yet, but I think it's in review. Basically, it's important to recognize the costs, and I think all of you know this. They're increasingly being shifted from the payers, the insurers, to the patients, to the beneficiaries. And so what we wanted to do is try to assess what is the actual economic impact on patients and on insurance. We looked at 5 and 10-year costs. With this model captured not just the cost of the device, but also the cost of what happens after the device or the drug. Cost of bleeding, strokes, and all of those things. The economic cost from the US perspective, and here's the data. Now, this is a bit complex, so let me just take you through it. If we look at Medicare, what you see is that appendage closure costs about as much as warfarin, and both cost less than NOACs. The reason, by the way, what are these costs? In blue is the cost of the therapy itself, either the device procedure itself or the cost of the drug. In green is the cost of the complications. Notice that the biggest green is with warfarin because that's where you have the most amount of bleeding and strokes. But if you look at the cost to patients, it's actually substantially less with appendage closure than it is with either of the anticoagulant. And I think this is really important because remember, whatever strategy you use, this is oftentimes an unplanned financial burden to the patient. So I would say both in terms of insurance as well as in terms of patients, appendage closure is certainly quite reasonable. Again, I'm not trying to suggest that you should put it in because of this, but I am trying to suggest that you shouldn't not put it in just because of the cost issue. Finally, in terms of where we're going, I think all of us are aware of the LAOS 3 trial. I think it's a really interesting, powerful trial because at the time of cardiac surgery, if you chop off the appendage or clip it or just get it out of circulation, what you see is that you have less ischemic strokes. And this is a relatively large trial of over 4,000 patients, 33% fewer strokes. One of the interesting aspects is mortality was no difference between groups. Now you can ask, well, why is that? Wasn't I just talking about stroke severity and reduction in mortality? Well, remember that in both groups, they stayed on the oral anticoagulant. So you don't have the benefit of less bleeding or less hematomal expansion and all those things. And not surprisingly, major bleeding rates were the same between these two groups. So I think the point is, does it make sense to consider a study of appendage closure versus NOACs? Well, I think it does. And in fact, there's a LAOS 4 trial that is going to start comparing very high-risk patients who are on oral anticoagulants to patients who take the NOAC alone or NOAC plus appendage closure as additive therapy to decrease stroke further. Will we see a mortality benefit in that trial? I doubt it, because you're not going to see a mortality benefit. Oh, I'm sorry. You're not going to see a mortality benefit unless you're off the blood thinner. But I do think we will see less strokes. I guess I did have one other slide. Let me just talk briefly about this. There are other concepts. This is, again, in clinical trials. This is not approved. This is a filter device, and the idea is to put these carotid filters, and you can see what these look like. Use them, put them directly, puncture the carotids bilaterally, and here you see the device that's being extruded. We actually did study this in a first-in-human study, and we showed that we could do this safely. And the plan is a large multi-center randomized trial called Intercept. This is really going to be concentrated on the patients who just come in with an ischemic stroke, a recent ischemic stroke, where the stroke rate is going to be high. The patients will be randomized to either oral anticoagulant alone or oral anticoagulate plus filter. A very large trial, almost 3,000 patients. Again, the trial has not started, but hopefully it will start soon. Finally, let me just talk about who should receive appendage closure now, today. Well, I think if you're suitable for anticoagulation, you should get oral anticoagulation. I don't think anybody would disagree with that. If you're contraindicated oral anticoagulation, then I think you should get appendage closure. Especially now, we can put the patients in, or put the devices in with just an antiplatelet transition. If you're high bleeding risk, these are the sort of the protect and prevail patients, then I think, yes, these are patients you should consider for appendage closure. There are also a couple of unusual categories. The sort of, let's say, oral anticoagulant failure, meaning a stroke on warfarin or stroke on NOAC. I think these are good candidates for appendage closure. And then those patients who we either advertently or inadvertently electrically isolate the appendage, because these are patients that are very high risk for stroke, even if you keep them on oral anticoagulant. So these are patients I think we definitely should consider for appendage closure. What if a patient is simply unwilling or unable to take oral anticoagulant? Well, I think in those, you convince them to take the oral anticoagulant. For these patients, we need the results of Option, Watchtower, Champion, and Catalyst before we routinely put in the devices. So I think there's a crescendo of data showing the benefit of appendage closure, both in terms of stroke reduction and more recently mortality benefit. The safety of the devices are clearly much better. I mean, you can put the devices now in with a 99.5% safety rate in terms of tamponade, and this is even higher at high volume institutions. And the important caveat to all this is most of the evidence is on the poor oral anticoagulant candidate. As a pure alternative, and I think I've said this several times, we really need the results of the forthcoming trials. So I think with that, I think I'll go ahead and stop. Thank you very much.
Thank you very much, Vivek. This was an amazing overview and real state of the art of this. Many questions are coming from the chat, but I invited two of our most junior attending here. One you know very well, and one is Dr. Zhang. So,
how are you doing, Dan? And hello, Dr. Zhang.
Dr. Zhang is one of our stellar implanter here. He has amazing imaging capability and technical capability. Has been doing all the Watchman with me and for me many times. And I wanted to point out, the socioeconomic aspect. For example, in our area, we have a mixed population, but we have a part of the population that really cannot comply. Sorry for the word again, cannot comply with compliance and really have socioeconomic problem with the expense of the NOAC. So I think the alternative would be to have a major stroke. So this device, I think, play an important role here. But Andy, do you have a question for Dr. Reddy?
Yes, thank you, Luigi. Thank you, Dr. Reddy, for the fantastic talk. I do have two technical questions. The first one is related to DRT, as you talked about.
Yeah.
And the DRT used to be a big concern post-implant, but the new design Watchman flags make it like less common. However, it's still there, and the DRT can like associate with ischemic events, and the timing part is really tricky. It's very unpredictable.
Yeah.
According to the trial, it can happen from like 1 month to over a year, which makes it very difficult to monitor. But the new Flex Pro device may be very encouraging. But before that, what's your strategy to monitor the DRT?
Yeah, no, thank you for that question. It's a very important question in management. A couple of points. Number one, I don't think we know for sure the Watchman Flex is that much better in terms of DRT. I think that data, we still need to develop that. So I think the DRT issue is still an issue. I agree with that point. Number two, the timing is an issue, but so I'll just give you our own strategy. So when we put the device in, whether it's the post-implant regimen, whether it's the 6 weeks of NOAC and 6 weeks of DAPT or the 3 months of DAPT, what we typically do is we do that, then we wait a month on baby aspirin alone, and then we do our first imaging. The reason we do it that way is because if a DRT is going to form, I want it to form before I image. If I image immediately at 45 days or 6 weeks, or that's the same thing, or at 3 months, then I haven't allowed a DRT to form. And if my next imaging is at 1 year, then the patient's going to have a DRT during that time and may develop a stroke. The reason you can use this strategy, by the way, is that the DRT, while it is bad and it's important, you don't get a stroke immediately. In most patients, it tends to be laminar, and it takes some time before a stroke occurs. And we have a lot of safety data that that strategy works. So that's why we do it at 4 months. So if a DRT is starting to form, we can deal with it. We also do a 1-year TE or a CT, and I've been pretty strict about that because actually of the reason you just mentioned, which is you can have late DRTs. It's a problem. Fortunately, it's rare, but it is a problem. What do you do if it happens? I think that's the other implication of your question. Well, certainly you want to put them back on oral anticoagulant or sub-Q heparin or whatever to eliminate the DRT, which you can do. But then the question is, what do you do after that? Because then if you put them back on a baby aspirin, some of those patients will develop DRT. I think the answer is we don't know. One of the intriguing ideas that some people are doing, which I'm sort of favoring, is to use very low NOAC, meaning quarter dose NOAC, which is such a low dose that the risk of bleeding is not terribly higher. It's very, very low, and yet seems to be, at least anecdotally, seems to prevent the recurrence of DRT. So I think, again, I guess my conclusion with the DRT is it is quite infrequent, thankfully, but it is an important issue. And, as you mentioned, the Flex, well, I mentioned, and then you mentioned the Flex Pro, hopefully that'll obviate this issue, but, this still needs to be proven. I hope that helps.
Andy, another question?
I have a second question is, what do you think the role of a 3D ice catheter like a Nuvera or Vericide, left atrial appendage occlusion procedures? Do you think it will replace the TE, become a standard tool, or do you think there's any limitation by doing this?
Yeah, no, there are definitely limitations. Listen, these ice catheters, as I'm sure everyone's aware, you don't get the same sort of, especially out-of-plane resolution as you do with in-plane resolution. And of course, both planes are not as good as the TE probe, which is just more crystals. So the quality is certainly less. Having said that, we can do it with ice, and it has some important implications in terms of the patients don't have to have general anesthesia, no TE probe. So I think it's a real advantage. My own feeling is that, but it does require expertise. It requires a lot of expertise. And, people like Luigi and Dan and people who are doing a lot of ice usage for ablation, I think for them, it becomes an easier track to using ice guide implantation. For those that are not doing as much ice guide implantation, I think 3D helps a little bit. I don't know that it changes things completely. If you look at the United States, and I'm going to probably fudge the numbers right now, but I think it's approximately 20% of the implants in the United States are done with ice. My guess is that will increase over time, but I doubt it'll ever become 100%, but maybe it'll get to 40, 50%. We'll see.
Yeah. Thank you. Thank you so much.
Dan, any question?
Yeah, this is a little bit maybe off topic, but we get a lot of questions about what to do with the patients who can't get any anticoagulation.
Yeah.
Or patients who are extremely high risk. One patient population that comes up over and over again is the cerebral like amyloid angiopathy patients,
Yeah.
where they say even a baby aspirin is going to cause an intracranial bleed. Have you dealt with this patient population, and do you have any suggestions on how to proceed?
Yeah, and there is some data. Look, what we really would love to see is some randomized data in this cohort. There is no randomized data. It's almost impossible to get equipoise between either the patients or the physicians to do these trials. I mean, you remember, Dan, when you were with us trying to randomize into ASAP too.
Yeah.
That's even those patients had some antiplatelet regimen. But there is some non-randomized data that's been published, multiple centers in US and in Europe, in these patients, even with no transition, not even an antiplatelet transition. And most patients do well, which also means some patients don't do well. And that is a problem. I think in somebody who has no other choice, what I would say is we have to think about what the options are. The options are do nothing, which means you probably have a high risk of stroke. Put the device in, but understand that a small percent may develop a thrombus on the device. And if there is, and you can't give an oral anticoagulant, you'll probably have to go in surgically to remove it. Or the third option is to surgically ligate the appendage right then. Also understanding, even with surgical ligation, you can get thrombus in that location. So you have three bad choices, okay? None of them are perfect. And I think that, you have to discuss with the patient and my recommendation is to discuss it with the patient, the neurologist, and discuss this as a team to decide what the best option is, because it's not a simple decision in those patients.
Thank you.
Vivek, a few questions. One from Dr. Ferrick from our group in EP. Do you know if a left atrial thrombus detected while on AC or in NOAC has the same embolic risk of a left atrial thrombus off AC? And what is your approach if this is detected as a prelude to a cardioversion or LAA deployment?
I'm not aware of any data of the embolic risk of a thrombus on versus off. My guess would be better if you're on, but honestly, I just don't know. In terms of if you do detect a thrombus, I think the first question you have to ask yourself, is it really a thrombus, right? We're all aware of smoky situations, so to speak, right, in the appendage. And one of the things you have to do, and of course we all understandably take the conservative position of, okay, if there's smoke, there may be fire and no thrombus in there. But I think the other thing we're learning is that when you have these low flow situations, if you give the patient, if you increase the flow, basically put them on isopril or dobutamine or whatever, or if they have a pacemaker, just pace the atrium faster. What you sometimes do is you end up clearing the appendage and you see there's no thrombus, or you clear it and you see, oh, there is thrombus underneath the smoke. So that's the first thing to do. Once you do that, then I think then you have choices, right? If it's a patient that can be on an anticoagulant, I would definitely put them on an anticoagulant. My own strategy is to use higher dose NOAC. So I do DVT dosing, so 15 BID of rivaroxaban or equivalent with the other drugs to try to dissolve that thrombus. Because just because it's easier than putting them on warfarin with the 3.5 INR, right? I mean, I just don't use warfarin as much anymore unless there's
Vivek, we have three excellent question from our chief of cardiology, Dr. Garcia.
Okay.
The first one is, should we consider all coronary artery disease patients high risk for bleeding having to be on an antiplatelet therapy or dual antiplatelet therapy sometimes?
Yeah, it's a good question. I guess, it's a great question. Of course, Mario is going to ask the tough questions here. So I think, look, there's obviously, the answer is yes, particularly if they have to be on triple therapy for a period of time. On the other hand, that's a transient exposure, right? They'll eventually get off of that, right? But if they do have to be on an anticoagulant plus an antiplatelet therapy because of Coumadin, yes, they are higher risk. Are they high enough risk that we should do appendage closure? I don't know the answer to that. We don't have, we've talked about doing a trial in that population. The trial never just got started. I would consider that somewhere between the champion catalyst patients and the patients that we implant now. So those, again, are sort of in between, and as in most things where there's no data, you got to have that discussion with the patient.
Probably the one with AFib, of course. We're talking about that.
Oh, yeah, absolutely.
Yeah.
Assumed.
So should we rely more on CT or TE for sizing the device and also follow-up? Because this becomes, an important workflow now that actually here our program is growing a lot. There's a lot of TE to be done.
Yeah.
And, CT is easier to schedule and to do. What's your point there?
I think they're both good. I think the key is you have to develop the expertise. The measurements on one tend to, like, for example, with T, you tend to underestimate versus CT, which tends to overestimate, or however you want to think about it. The point is they're slightly different. So I think when you start using a new imaging modality, then you're going to get slightly different types of numbers, and you'll find yourself either going higher or going lower on the device size, right? And in terms of follow-up, just understanding what it, particularly on CT, what is healing versus what is thrombus. And that, I think, the good news is there's lots more data that's being published on that issue. But I think they're both reasonable.
And the last one he has is there clear data that if you have a leak, continuing anticoagulation, reduce the stroke risk, or you have to close it?
Yeah. The answer is no. There's no clear data in terms of, there's no randomized data. But having said that, there's very good non-randomized data. One of them, actually, Luigi, you published with Andrea, where you had patients who, after device implantation, you kept on low-dose NOAC for a long period of time. It was actually a complex study with other arms in it, but I'm going to talk about the one arm that's relevant. And those patients had an extremely low ischemic stroke rate. Actually, they had no ischemic strokes. There was a TIA, but the point is a very low ischemic stroke rate. So I think the suggestion is, yes, doing that will further decrease the risk. Now, whether or not you should put everybody after implantation on low-dose NOAC, I think that's a different question. That's like a LAOS 4 type of question.
And that's actually opened me the question of what do you think about our data on low-dose NOAC? Of course, after a leak or after an implantation for arthropathy, but in general, as a post-implant strategy.
Yeah, it's a good question. Look, right now, with imperfect devices, where we have some DRT, but probably more importantly, where we have leaks still, I think this low dose strategy, there are a lot of reasons to like the idea. Low dose probably doesn't result in as much bleeding as high dose. I think that's obvious. As devices continue to improve, just as drugs will continue to improve, right, with the factor 11, I don't know that this sort of double therapy makes more sense. I mean, there are important cost issues. I'm still convinced about I'm convinced is the wrong word. I'm still concerned about the mortality issue with double therapy. So I think that it's reasonable, particularly in high-risk patients who had a previous stroke or whatever. But as you know, most of the patients we're implanting now, we're trying to get them off anticoagulation for bleeding issues, for compliance issues, for a number of different issues, cost issues, etc. So I guess my answer to your question is I think it's interesting, and certainly I think it's useful, and I do employ it in certain patients. I don't do it routinely at this point.
There are a lot of questions coming, but we are running out of time. We use the last 3 questions. Number one is, we know now we can use dual antiplatelet in patients that really cannot do anticoagulation or low dose, but as Dan asked before, for people that can do anything, how comfortable you are in placing a Watchman device or another device and giving no anticoagulation? There are data in Europe on this.
Again, I'm not comfortable, but I'm even less comfortable doing nothing. How's that?
So you prefer better than doing nothing?
Absolutely.
Number 2, technical question from the cardiologist here. Patient with a Watchman coming for cardioversion of AC. Do you image the patient? Do you do 1 month anticoagulation after? Assuming there was no leak and nothing, the patient was imaged already.
The post-implant patient. Yeah, this is a great question. There is some data on this, right? So the major question that I ask myself is, did the patient, how concerned am I that the patient may have a DRT at this point? If the patient's not had a recent TE or CT, or let's say it's early enough, right? Then I would image them. And I do appreciate there's some cognitive dissonance in saying, okay, let's image him just because I cardiovert, but I'm not going to image him if I don't cardiovert. I get that. But I think that when you're actively doing something, there is a certain amount of
But how about the anticoagulation post? Let's assume there is
post-implant?
No, post-cardioversion.
No, I got it. I'm sorry, post-cardioversion. Yeah, no, I don't see it. I mean, Of course, there's going to be some stunning, but who cares? The device is already there. So I don't.
But you know what? I mean, I'm personally worried about stunning or something. So why not to give like a 1 month anticoagulation? I mean.
Yeah, look, I don't. It depends on the patient, obviously, and the indication for the device. But in general, I mean, the stunning issue, all the data I've looked at are stunning with thrombus forming in the appendage. If you've already occluded the appendage, I just don't see it, and that's just not our practice. I fully appreciate there's no randomized data in this for this question, though.
Last one, timing. Considering ablation is, forget about it's approved now or not, but considering ablation is not a 100% success rate, let's talk about paroxysmal patient. What's your timing for the occlusion? If you could do in every patient same procedure, would you do, or you like to wait that you have a success? And if you have if you implant it, does the redo expose the patient to a higher risk?
Yeah, I'll make these points very quick because I don't want to run out of time. But the first, I am not convinced, even if option is a positive trial, which I expect it will be, that we'll be doing this in every patient. I do believe in atrial kick. I don't want to include the appendage in lower risk patients. Okay, so I think once option gets published, we'll have a debate amongst all of ourselves trying to figure out which are the ideal patients that we implant, because I don't think we're going to be putting in everybody. Number two, in terms of timing, I think that with the advent of pulse field, which as you're well aware is happening at the same time, pulse field ablation, even with the device in position, we'll be able to isolate relatively easily, the appendage that is. Well, maybe not easily, but easily enough, let's say, okay? So I have a feeling that we're not going to get as worried about the potential for a focus coming from the appendage that we can't easily reach. That's, I think, an important consideration now, but I think 2 years from now, that's going to become less of a consideration. That's what my guess is going to happen.
There are many more questions. We'll probably have to contact you on the side. We really appreciate it. We have a growing program, yes, here. Yesterday, we beat the record, I think, in the area of New York. We did 7 Watchmen in one lab, 8:30 a.m. to 7 p.m. So
that's excellent.
It was a good record for us. And I cannot thank you enough for being with us today, and for your expertise, your time, and your dedication to science. Thank you very much for being with us.
Thank you, everyone. Thanks for having me. Thanks, Luigi. Thank you, everyone. Nice to see you, Dan.
Great to see you.